Hi, everybody. Welcome to be here. It's been, this is great segue. We're going to be talking a lot more about urinary infections. Kidding. We're not going to talk more about urinary infections. We're going to talk about other stuff. Can you raise your hand if you're one of the interns? All right. I have kind of designed this presentation for you. So the rest of you, just so you know, I'm hoping to kind of get a beginner's audience into some predictive modeling concepts that we're talking about. The title was originally Advanced Analytics at an Academic Health Center, Current Status and Challenges. We have many, and so I've kind of focused in on one. I'll tell you a little bit agenda for this. Who are you? What did you say you do? And advanced analytics sounds great and all, but can you tell us about AI in healthcare? So we're going to try to go over some of those items. Hopefully they'll be of interest. But also, there's a few key takeaways I think you'll find. So who am I? Peter Graven. I have a PhD in health economics. My technical role at OHSU is actually lead data scientist. I'm in the IT department here. I've been there mostly because we sit on top of all the data, and it's a good place to implement predictive models and other things. I come from a background in research, both policy and a lot of kind of methodology. I lead an analytic services program there. I am technically an assistant professor at the School of Public Health, and I teach health economics there. But as I'll say again, I'm really a health economist, and you'll see that comes up occasionally. What do I do? So as lead data scientist, I'm doing predictive models. I do forecasting models and kind of advanced analytics. For a hospital system, that's really anything statistical in nature. A lot of people do reporting in our healthcare system, but not a lot of people are kind of analyzing it with a statistical lens. And then as part of leading our analytic services program, I'm trying to consult with on high priorities to the institution and understand their analytic needs. And like I said, we sit on top of all the data, and so we have access to many tools to answer questions that are pertinent. All right, so advanced analytics sounds great and all, but can you tell us about AI in healthcare? And I'm going to do, this is going to be kind of a cursory look, but it's going to lead us to a couple takeaway points. So as if you kind of read if you watch the news, if you listen to popular reports, artificial intelligence is changing the world around us, right, in many sectors. Just looking up artificial intelligence, if you go to Google, you got your predictive typing, right? So it's already trying to predict what you're going to get. It's going to give you some predictive results. So just starting there, we already know that AI is trying to understand what you're thinking or what you want before you get there. Speech recognition, obviously we've seen that deployed in many settings of being able to figure out all those sounds that you are putting together. What does that maybe mean? What are you trying to say? Visual perception, the ability to understand what images are. That's a form of AI as well. And then marketing. And I'm going to talk about this one a little bit more. We see AI in marketing quite a bit. That is your Facebook feed that's telling you all the things you want to buy maybe. There's a reason why we're going to compare that to healthcare. And I'll tell you a bit more about the marketing examples. In marketing, a lot of times it's something as simple as a product recommendation. How do I know what product to offer to a person? If I could figure out that, then I have a whole bunch of products I want to sell, and they actually probably want to buy a bunch of them. And so making that connection is something that we've seen from AI in terms of machine learning, right? And having big data sets about people's behavior and being able to train a model that can then look into the future and figure out what you might like and modify itself. Image recognition. Maybe you search for one kind of jacket or shirt, and now when you search again, it's going to say, I think I know what they were looking for last time based on what was in that image. I'm going to probably give them a bunch of other images that look like that. So finding a pattern there. They use marketing to understand like all your chats online, your mood maybe, what you're thinking about, your complaints. They might want to fix your complaints before you leave their company. Demand-based pricing, another thing where they're really looking at how your behavior in terms of how much you're looking for things. Maybe we're going to raise our price because of that. So anyway, there's a whole bunch of cases in marketing, which I think has captured people's interest in many ways about AI potential in healthcare. So we're going to transition a little bit. And why is AI in healthcare different? I'm going to tell you a story a little bit about why, about predictive modeling, and hopefully this will kind of give you a sense of it. So I get this a lot in my job, and someone says, hey, let's predict the risk of each patient, right? And so we're like, you can do predictive models, right? Find out which of my patients is risky. Let's go build a model. And I say, well, okay. I'm glad you're so excited. You'll see the exclamation mark there. Do you see how excited they are? Let's predict the risk, and maybe this will save clinician time, and we'll be using AI, right? So it sounds wonderful. And then I'll just have like a little question. So what model should we build? What's risk of what? What are we talking about, right? Is that the risk of cost? If you're the insurer, you're very interested in a patient's risk of cost and what kind of costs they might have. But if you're a healthcare organization, maybe you're interested in other things like risk of them coming to your hospital for an admission or an ED visit, right? These are expensive things, but there are also times when the patient's truly sick, right? And so maybe there's some ways we can get ahead of that. First question is, risk of what, right? And so this is something that people, they brush over. The word risk seems to cover everything, and we want to, as you think about predictive modeling in the future, we're going to have to go many layers into what do you mean by a predictive model, okay? The first layer is risk of what? Yes, they decide. Yes, let's predict hospital admit or ED visits. That sounds perfect. That's what we've always wanted to do, all right? But what will we do to prevent that admit or ED visit? Oh, good question. Yeah, we have these list of people that are going to have an admit or an ED visit. What are we going to do about it? Well, I don't know. Let's look in our bag of interventions. We'll indicate the patient for care management. We're all done. See that other exclamation mark. It's all settled. We're going to do care management. All right. But the question is, does care management work for all patients? Probably not, right? You're going to have some patients where they're going to respond really well to whatever it is care management is doing. How many people have ever worked in care management? Thanks. Good. A couple experienced people. Now, what do they do all day? We might not know, right? They certainly do, and they probably have different approaches for different patients, right? So that might be something that they try one thing with the patient to see, hey, why don't you come in? I'll give you a call, remind you of your visit, help you set up your next one, think about a good path for you. But maybe they're like, I don't want to do that. I don't want to come in. And they're like, oh, wait, I got another option. We're going to try this other thing with this patient. And so they might have a variety of different things they're doing. So care management might just be kind of a big blob, or you can start thinking about what are their bag of tools that they have. And so then you're thinking a little bit further down the line, right? We started out risk, then we got down to hospital admin ED. Now we're really trying to predict who's good for care management, right? Now we're getting a lot closer to the things that people might like. Okay, so let's predict the patients that care management works for. We're done. We did it. That's great. Now we got a really fancy model. Except for what does care management do? So we kind of alluded to that last question. We don't always know. Maybe they generally engage, or maybe, like I said, they have different approaches for different patients. And then here's where it gets tricky, right? How do we know if it works? How do we know if care management is working? We started out talking about predictive models, and now we're trying to figure out if something works. I guess you could just go and compare the ones who got care management to the ones who didn't and see how they did, right? Did the ones who got care management in your past, did they have fewer hospital admits, fewer ED visits? Seems pretty straightforward, right? What's the problem with that? The ones who got care management were probably sicker to begin with, right? We picked them for a reason. So we can't just say, oh, the ones who got care management went into the hospital, 20% of the time. The ones who didn't went in 10% of the time. It looks like care management might be bad for you, right? So basic scientific method here is we need to be really careful about how we decide if something works and what's going on with it. And so in this case, it might be that we can't just do an easy comparison of our populations. Mostly for the interns here, does anyone know what would be a good way to try to assess if it works? What would be a good way to determine if something called care management was working for a population? Is there different types of studies that might be effective for making sure that there's no other things affecting what's the result of the patient? And so you can keep thinking about that. I will give you the answer, don't worry, because we might run out of time. So we have different study types that we do on patients, one of which is the randomized control trial. Has anyone heard of that? You guys heard of that? So this one has a great advantage of, it's going to get rid of all that stuff I said of, oh, we decided that this, we're going to look at the data for the ones who got care management versus the ones who didn't. Instead, we're going to randomize a whole bunch of people that probably could get care management. Some will get it, some will get something else. Then we're going to follow their path and see how they did. That is the ideal way to figure out what care management is doing and if it's working, right? So if we knew that answer for who it works and how well it works, then we're able to go back to our predictive model and know what kind of people we want to look for. So I said, do we have a better way to determine if something works? Yeah, this is where we do, yes, we can use tools of science to determine the effective interventions. And so we started out talking about predictive models. I'm going to make you talk about interventions because in healthcare, that is how we change the path of a patient, right? We're going to go do something. The data, buildings worth of data are not going to make anybody healthier. It's going to have to take some interaction. And so, unfortunately, as someone who is not allowed to touch a patient, that's disappointing, right? So I don't get to make any patients better. But what I can do is help models that allow clinicians or the healthcare system, right? We're not just medical. We could be thinking about public health outreach and different items, but we want to think of models that there's a real intervention involved. And so we can perform a study of effectiveness of care management and see what works and what doesn't work. I actually want to do this, right? Let's go ask what's an easy way to do this without a randomized control trial? You could just go ask a care manager, give me your list of 100 patients, tell me which ones you were effective with, which ones were non-responsive. Let's go look at the characteristics of those patients that you felt like you were able to make a difference with. Then we have a better idea of then we're not wasting the care manager's time, and we're better understand who is right for this treatment, which is, in this case, a care manager. So if we can build a model to find those people, that is the data science that I'm aiming towards, at least in our models. Now, do we do this every time? I can tell you no. But as people who are thinking about predictive models and the excitement about it in healthcare, recognizing that you're going to always want to peel back those layers of it's not just risk. It's not just risk of what. It's who's going to respond well to the intervention, right? And so that's kind of the mantra I'm trying to describe to our leaders, people who are directing resources in terms of what can models do for us, is thinking about each intervention and what model is best for it. And so the principles of predictive modeling that I think are important right now is to flip the script. Unfortunately, we've gotten distracted by the modeling itself, which is very cool. You'll learn in statistics and machine learning classes. You can do a lot of cool things. It's fun intellectual exercise to figure out how good you can make your model and the different tools. But that model is going to do nothing unless we have an intervention that goes with it, right? So I would actually say go the reverse way. So find an intervention that works. That's hard, right? That means clinicians sometimes don't always know if they work, but that's part of being at an academic health center is we're trying to really decide, what things are working, how well they work. If we can find something that works, then and we might be doing that through all the trials and experiments that we usually do in science. Then once we do that, then we can go find a model that matches the interventions to the people, right? And so I always say, tailor the model to the intervention. I guess there's a little edit here, but there's a model for that. And that is, a lot of people are saying, we only want one risk model. Right? So I've been in discussions where people are like, there's competing models out there. I just want one model for the risk of the patient. And I'm like, I'm sorry though, that's not going to be, That's a very simplified version. That might be great because you just have one score and all your different reports for risk. But we know that that's probably not very useful because it's risk of what? Risk of for what intervention, right? That's the way the modeling is best designed as far as I can see. And so I want to encourage people to say, if you have an intervention that works, we can go build a model for it. And because of that, that's a lot of models, right? Every intervention, we're doing a lot of things in healthcare. Hopefully we know what we're doing. A lot of times we haven't tested it. But each one of those things, I think, probably deserves a model. If you can show that it works, a data science team should be able to build you a model that isn't too time consuming. So that's, a big thing about healthcare data is, remember when we were talking about marketing, they know what works. Their product, every time, right? If the person sells, if they sell the product, that's a win. That's a success. In healthcare, we don't always know what the success was. We don't always know what we did, right? That triggered a change in the health of a patient. And so those fundamental issues that we have in healthcare are not something that they face in marketing. In marketing, if you send out 100 ads and 70 people don't care, that's fine. You got 30 hits. That's great, right? In healthcare, if you perform 100 surgeries on someone and 70 didn't need them, that's not good, right? We can't take those mistakes. And so I think recognizing that in many of the other spaces where we use data science, the risk of failure is much lower. It's not a big deal. And also, the knowledge of what intervention are you going to deploy is actually a lot more known. Someone might like my product. I give them an ad. I give them a link. They're probably, pretty easy to know what to do after that, right? Whereas in healthcare, we're figuring that all out. It's a lot more complicated. And so now, it's both, I would say, daunting, but also kind of exciting, right? Because this means that we have, there's a whole bunch of interventions that I've never seen models for. There's a lot of things to go build. There's a lot of engagement with clinicians to go and try to figure those things out. Other factors that affect predictive modeling, we need to be able to display risk factors. And so when you did your predictive typing about Google searching something, it doesn't tell you why they picked that phrase for you. There's a whole bunch of calculations that went with it. But it's really important in healthcare that we know why something was selected for a patient. Partially, it's because clinicians have a very curious mind, and they also want to be in control and command of what's happening to the patient. They need to know why. They can be sued if they don't know why, right? And now, does that happen all the time? No, but in the back of my head, if I'm thinking about building a model, I know that they better agree with why that model was saying that patient deserves that treatment, because one day they might have to go tell someone why they chose that. And so it raises the bar. We can't make mistakes. We have to raise the bar in terms of why we made a prediction, what were the data that went into it, and all those things. That's not something. If you send out an ad to the wrong person in marketing, who cares, right? It probably costs you 10 cents, And so the other part is of that is if you're going to display the risk of a predictive model, you need to have probably a good visualization or some way to do that. And so there's been different approaches for that, and lots of people are developing space. But it's not something to forget, because I know there's been people sending out risk scores for years that have been pretty much unusable, because if you don't know why someone's at risk, then you can't take the next step, okay? And related to that is, how do you get the predictive models into the workflow? That most electronic medical record systems will have some ability to do that. Luckily, we're also developing new applications that kind of can interact with those systems that are more open source, because that way we have more flexibility in how we want people to look at the data that we've been working so hard to generate. There's a couple other slides that may have not made it into the last set here. So one question is, so why is a health economist working as a data scientist, right? And the couple arguments I would say is, for one, economists are trained in statistics, we have our own version that's called econometrics, which you may have heard of. It's essentially statistics for economics, just like biostats is statistics for the biological areas. Each type of discipline kind of has their version of statistics, which has been in some ways customized. They may have innovated and developed in their own area. Computer science turns out to have, they're learning statistics. They've also developed a ton of algorithms that have really capitalized on the ability to use computers to help with a lot of the calculations. So that's one reason health economists is doing predictive modeling. Another reason is that this issue of causality, right? So we talked about, how do you know if an intervention worked? Well, if you just looked at the data, you might say that the correlation between the care managers and the ones who got care management versus the ones who didn't, it looks like there's a relationship there. But we know in many cases people are actively choosing their environment around them. And that's something that economists are used to. I've sometimes compared it to epidemiology, which is more of an approach that you're exposed to things, right? You're not choosing your environment as much as you're being exposed. And in the past, they were less likely to believe that there would be these causal kind of endogenous issues that are going on. Now the methodologies in epidemiology have gotten a lot better, and they're much more able to understand that there are, to develop a causal relationship, which is what we need for interventions to understand how they work, requires a little bit more sophisticated methodology. And then the other question that you might have for an economist is, what are the, for AI is, what's the impact on jobs? Is this going to does AI eliminate jobs? I think that's a common one I've heard sometimes. And I think what I've hoped to kind of show you a little bit here is there are more jobs. Tailoring every intervention to a model, that's a whole bunch of work that, trust me, we have not figured out how to do that with an algorithm. It requires going into figuring out, aligning the science with the, with the model and then making all the customizations of it. So I think there's a real, I think there's a lot of work in this area to come. And so people who've said to me, AI is going to get rid of all these jobs. Certainly not if they're not if you're one of the ones who are building models, and not even people who are kind of interacting with them. There's a lot of human things that needs to happen for these to work. And so those are kind of my main points that I wanted to bring out today. Questions?
Same transition, and I'm just curious where you see sort of where along that spectrum of modeling you think healthcare is, and how long it'll take to get to the interventional modeling or building models for interventions. Or and how many are out there now, and kind of where we are.
We are definitely in the beginning steps. I can tell you at OHSU, we've had some basic rules that have existed in our healthcare system to help understand risk. We are, just deploying some of the active real-time models right now, and there are, less than a dozen of those, I would say. But I see it really flourishing once we get the systems down into how do we deploy, how do we evaluate it, and make sure that everyone's protected. There has been some real resistance to.
That's my follow-up question.
Yeah.
What kind of resistance?
There's various kinds
how much?
There's various kinds of resistance. So, initially a clinician will usually look at it historically and say the score is wrong. And if it was a black box, you had no way to say otherwise. You're like, why? I don't know how it was calculated, so I can't tell you. But now, like I said, if you can display the risk factors, now we kind of can walk through. And of course, on the inside, we always know it's usually being calculated correctly. Whether or not it's reflecting the patient is something else. But so there's always how accurate is a score. Now, that kind of subsides after time as they get exposed to the prediction and patient, they start seeing the pattern of, okay, it's mostly right. Okay, it thinks when they're married that really reduces their risk a lot, right? Maybe the clinician kind of discounts that a little bit and say they warm up to what the score is really telling them over time. So that is the main thing, is just getting people comfortable with the idea of, how do I trust this enough to feel like it's better than me scouring through the chart by myself? Does that answer your question? Yeah.
Great presentation. I had a question about whether, I'm curious, in any of the predictive models you've done, whether any of the interventions have been patient education. I'm wondering if, what the results have been with that, and I feel like that would be.
Like, what kind of patients might
Well,
need
most,
education?
no. So, like, a lot of what is done, like, in a clinic is not, like, the intervention itself sometimes is just patient education about the issue.
Yeah.
And, how that would sort of fit into the predictive modeling framework.
Yeah, so it's probably not going to go into the modeling itself, but like I said, so the process there would be, all right, we think that there are some patients out there who aren't, maybe using the healthcare system quite right, and we think some education will make a difference. All right, so we're going to go flag all those patients that we think we're doing that, and now let's go look at factors that might predict that, right? And then we could go and try to deploy a model that says, all right, we're pretty sure these guys, they have this weird behavior. First they go to the ED, and then they go back to their clinic, and then they look like they don't know how to manage their diabetes in the way that we're kind of hoping that they will. And maybe our intervention is like, let's do education on what happens when your sugar changes and what you're going to do next or whatever. So there's a model for that, right? Have we done that? Not exactly. We do have a model actually that we're working. Ian here is one of the interns, and we're cancer patients have a lot of things that come up. Their bodies are doing weird things under chemo, and it's unexpected to them. They get nervous. They end up in the ED. And so part of it is us trying to give them more information about what might be happening with them, how serious is it. And so there's a monitoring device, an iPad basically, that will help them kind of walk through symptoms that are very common but new to them, right? And so in a way, that's kind of like an education thing. Yeah.
So thank you for your presentation. I'm also from an economics background, and so I'm wondering, as an economist, we cover a lot of kind of ethics of large-scale implementation of things. I'm thinking specifically in development economics of like public health incentives and actions. But I wonder what your thoughts are on the ethics of more individualized implementation, specifically regarding the random control of kind of selecting at random who gets a certain intervention versus who doesn't.
Okay. Yeah, so now we're going back to the science part, really, of thinking about how do we know if something works, and the randomized, the kind of the process for setting up a good study. That part where I said some people get care management and some people don't, that was a flip of the coin, right? How do we decide that that's okay for patients to not get something? And that's something, so, as you get more exposed to research, there's something called the Institutional Review Board, who's going to review your study and has certain ethical principles in mind of, are you withholding something that everyone knows is already good for a patient? That's probably not going to be okay, right? They're going to say, nope, we can't do that study. Now, if there's something about it that we don't know, if there's uncertainty about it, and we don't think that they're being withheld good care, then that's something we can randomize them to. But that's actually a very broad research type question of can we withhold care? Are we really withholding it, or are we experimenting? And there's been, unfortunately, if you go into the history, there's been many terrible examples where researchers have gone too far of experimenting on stuff that they shouldn't have, at the consequence of the patient. So we have much better protections now. So, but it still comes up. So good question. Any other questions? Mm-hmm.